Good afternoon, everybody. So, it's me standing between you and drinks. And the first thing I want to let you know is that I'm a recovering alcoholic who hasn't had a drink in 12 years, so I might keep you here for a few hours. But I do bring that up for a reason, and I used to not share that I'm a recovering alcoholic, and I used to be almost embarrassed of it. But what I've come to recognize is that it's really a symbol of change, right? It's a symbol of overcoming something difficult. And as Jonathan mentioned, I work with employers. It's what I've done for 20 plus years. And there is an incredible inertia to continue something that everyone admits they don't like. And that inertia is pervasive, not just among employers, but among employees. They all want Blue Cross and Blue Shield. And when I ask them why, they say, because they're the best. I said, what are they the best at? And they say, healthcare. And I say, actually, Blue Cross doesn't provide any healthcare whatsoever. None. Zero. One of the major problems that I face is that in this country, we intermingle the words healthcare and health insurance as though they're one and the same. We don't do it with cars and car insurance. We don't do it with homes and homeowners insurance. We know those are two completely separate things. And we perpetuate this, especially in the employer space, because we spend 99%, maybe 100% of our efforts, and when I say we, I mean brokers, human resource departments, carriers, educating their employee population on the benefits of their insurance policy. What's covered and what's not covered, when the deductible applies, when the copay applies. Let's apply that to a different scenario. Let's pretend that you're teaching your children how to drive a car. Can you imagine if you spent 99% of your effort in doing that, educating your child on the provisions of their Geico insurance policy, and only 1% of the time, if that, on how to actually safely operate a vehicle? One of the things I think needs to happen is we need to start to teach people how to be good patients, how to ask questions, how to find the right provider, to know the cost and the financial impact. I imagine there's not a lot of people in here who support universal health care, but even for those who do, I talk about how the problem isn't who's paying the bill. The problem is how much the bill actually is. And universal health care doesn't really solve the problem for many levels because, first of all, what we need the most is an improvement in quality and a decrease in cost. And I challenge anyone to find one thing that our government has taken over in which those two things have occurred. But what is occurring, what I am seeing, is this is applying so much pressure to our world that it's bubbling up in other areas. I mean, again, I don't want to bring politics into this, but as Jonathan mentioned, we often save around 40+% year one on an employer's spend. Can you imagine if we did that on the entire spend in the country? We're now up to $3.8 trillion in healthcare. If we cut that in half, the border wall, for example, would be pennies in comparison. It wouldn't even be a concern, whether you supported it or not. It's going to taxes. It's going, I think a lot of the divisiveness that we're seeing in Facebook and the politics is indirectly related to healthcare. It's indirectly related to healthcare because it has to do with the haves and the have-nots. It has to do with how much money people have. And there's a few slides in my deck that are going to show you some of where this is going. So when I talk about restoring the American dream, I really believe that a lot of what we feel has been lost in this country is directly or indirectly related to healthcare. So when I'm talking to employers, and that's what I think the perspective that I want you guys to have today is what I'm dealing with when I'm dealing with employers and what they think, because half of all healthcare in the United States comes through the employer market. So the first problem, and if there are any HR people in here, I love you guys to death. However, what has traditionally been done at the employer side is they have pushed the benefit decision-making predominantly to HR. Now, maybe 30 or 40 years ago, when this was number 27 on the P&L, maybe that was appropriate. But just so you know, for most employers, it's in the top 10, often in the top 5, sometimes in the top 3. I've even seen it number 2 behind payroll. HR, it's unfair to put them in charge of that. They are not trained or qualified or educated or experienced to make such a financial decision. Now, they're super important once that financial decision is made, and we now move on to how do we support the employees around those decisions. And that's what they're trained for. And so the first thing that we want to get employers to do is to start to think of their healthcare spend as a business unit. Because when they think of it as a business unit, as they probably do other things that are lower down on the P&L, they start to assign different resources to it. They start to assign different demands and questions. I often compare to an employer, I ask them, I said, imagine for a minute if American Express came to you in a similar way that Blue Cross, United, Cigna, Aetna does. They came to you and they said, hey, Mr. Employer, we'd like you to give an unlimited American Express card to every single one of your employees. And we're American Express, so you can trust us to manage all your corporate expenses. And what we'll do at the end of every month is we'll just give you a bill that says, please pay us $143,322.49. There's not an employer in the world that would accept that. They demand itemization, transparency. Where did their money go? They also demand tools. I know as a business owner, I can put on my American Express cards that you can't spend more than $150 a night at a hotel, or more than $50 a day on food or rental car. And then I can see if that actually happened. But in healthcare, employers have put blinders on. And that's allowed this to become what it's become. And what it's become is this. And when I talk to employers, it's this slide, which is probably the ugliest, least compelling, least graphical slide. But this is the one that hits me the most. The top line, so this is from the Kaiser Family Foundation, and it's looking at 2010 to 2015. And it's showing the top line is what's happened to the average person's deductible. It's gone up 67%. The average premium over that time frame has gone up 24%. So you're getting 67% less benefit for 24% more premium. And at the same time, their wages have gone up about 10%. So when I talk about the pressure, when I talk about that divisiveness, that fear, people don't understand that even though they got a raise, they're taking home less money because not only did what was coming out of their paycheck go up from $100 to $200 a paycheck for their health insurance, but their deductible went from $3,000 to $5,000. And one of the interesting things about employers that I found, and I really saw this when I moved from New York to North Carolina 14 years ago or so. When I moved to North Carolina, there was a law, a regulation in Department of Insurance that said employers must pay at least 50% of the single premium. What employers heard was, we should pay 50% of the single premium. And I think the same thing happened in Obamacare. Obamacare, one of the provisions was to cap the total out-of-pocket, right? And it's gone up because it has inflation into it. It's now at $74.50 for an individual, I think, and $14,900 for a family. What most insurance companies and employers did was, instead of seeing that as a cap, like this is the worst you should ever be, they see it as the de facto standard. And Obamacare also limited some of the levers that employers and insurance carriers could pull. But one of the things that it did allow them to do was inflate the out-of-pocket. So let's talk about this for a second. Let's pretend that I'm the average employee. Now, the average employee today has a $5,142 out-of-pocket before the plan picks up 100%. That's the national average. That same employee, as a national average, has somewhere under $1,000 in their lifetime savings account. So let's say that that employee has a chronic condition. Now, the other thing I didn't tell you about was I lost a lot of weight about 5 or 6 years ago, about 210 pounds, and I was type 2 diabetic. I had elevated hyperlipidemia, hypertension, the list goes on. And I had expenses tied to that. Now, I make more money than the average American, so for me, I could afford it. But the average American who has those chronic diseases, you know what they do? They don't go see their endocrinologist as often as they should. They don't take their medication the way they should. Maybe they split their metformin. Or maybe they check their blood sugar once a day instead of 3 times a day to make their test strips last longer. And what do all those things do? They increase the likelihood of a large claim. Now let's talk about what happens when a large claim occurs. So let's say that employee has some sort of emergency event, goes to the emergency department. He still owes that $5,142 that he didn't have before, right? So what does the hospital do? The hospital puts him into collections, often puts him into bankruptcy. It may not surprise the people in this room to know that medical bills is the #1 cause of bankruptcy in the US, but what may surprise you is that nearly 75% of those people had health insurance. It's not the medical bills that are bankrupting them. It's their exposure under their already very expensive health insurance plan that is bankrupting them. But it gets worse. You can't get blood from a stone, so that hospital eventually writes that off, right? And we know this because you can pull the financials of any nonprofit hospital, which the majority of them are, and what you'll see is their billed charges go up and up and up and up and up, but the amount they're actually collecting is relatively flat. So when they write off more and more bad debt and they see this bad debt on their balance sheet going up and up, that's fodder for them to go to Blue Cross and United and Cigna and Aetna and say, hey guys, because you're slinging all these high deductible health plans, we're writing off more and more bad debt, so we need an increase in our reimbursement rates. Now, why would Blue Cross agree to that? Well, there's a lot of reasons. One I'm going to show you is that benefits Blue Cross. But the other reason is that carriers have 2 real customers. Their real customers are first and foremost their shareholders. That is first and foremost. But the second is the large hospital systems. Where are we? Here in Dallas. I don't know one of the large hospital systems here in Dallas. Anyone know one of the big ones? What's that? Baylor? Baylor, okay. So let's pick a huge employer. Isn't Dell here in Texas, right? Let's pretend Dell is with United Healthcare, and Dell leaves United Healthcare. Do you think United Healthcare is going to even really notice that on their balance sheet? They're a $240 billion company. They're not even going to notice it. But if Baylor left, every single employer in that market is gone. So they have to keep the hospitals happy. They can afford to lose any employer. They can't afford to lose any hospital. And I'll tell you what, if any of you know what's going on or what has been going on in Western Pennsylvania, between UPMC and Highmark, Blue Cross and Blue Shield, you know that fighting the carrier as a hospital or the hospital, the carrier, either one fighting the other, it results in pretty ugly territory. So, I'm going to show you why the insurance company has financial incentive to agree to that higher amount in a minute. But ultimately, we know they're agreeing to the higher amount, right? Because costs are going up. So, insurance company makes an agreement for a higher reimbursement rate or less of a discount or more of a discount off a higher number, whatever, it's all the same. What does that do to the premiums of the insurance plan in the area? The next year, the premiums go up, right? Because they're paying out a higher reimbursement rate. So the average broker comes into that employer and says, hey, Mr. Employer, your rates are going up 22%. And I know that's way more than you can afford, so we can raise your deductible and we'll get it down to 14% instead of 22%, something you can actually budget for. And brokers are even worse because what they do is they spin this higher deductible as consumer-driven healthcare. They're saying that by putting more skin in the game, they'll be better consumers, but what they're not doing is giving them any tools to actually be a better consumer. They're just saying, here's more pain, we hope you do the right thing. But that right thing is leading not only to increased costs, but decrease in the quality of care. On the family side, things are even worse. This is looking at a longer time period, so it's not really apples to apples, but the whole point of this slide is to say that what employers are doing is shifting costs more and more, both in terms of premium and out-of-pockets to the employees. And it's even worse if they're trying to carry a family. I know spouses that work just for the health insurance and nothing else. So what makes up healthcare costs? there's a lot of misinformation out there. This is from Milliman, who I think has a booth here. A lot of employers are told it's emergency room care. That's where the money's going. Emergency room care falls into that 4% bucket, among many other things. The money is really going to inpatient, outpatient, professional doctor services, and pharmacy. And I show this to employers. A lot of you in here probably know this is similar, but I want them to understand first and foremost where the money is going. 50% is going to the hospital. 50%. And if you add in pharmacy, most of which is unnecessary, we're approaching 70% of costs are going to hospitals and pharmacy. Why does this keep happening? Well, really, we have an issue of competing interests or misaligned incentives. If I put a real map of our healthcare system up, it would be even bigger than this. But this is the flow from an employer's perspective of what's going on. Now, they don't see most of this, and they don't know most of this. Most employers are either fully insured or self-insured with one of the large carriers, and they come to you and they say, look, we make everything easy, just in a box. But this is a lot of what they're hiding, and every step along the way, not only is there a markup, but there's opportunity to capture additional revenue. And that's some of what I'm going to show you. And I'm hoping that for those of you that are clinicians or providers or facility owners in the room, that you start to understand some of the headwinds and why common sense, high quality, high value care isn't widely accepted. Why Surgery Center of Oklahoma doesn't have a line of people out the door and around the block. I'm going to not call her out by name, but there's a woman who works for a company. I love the company. They're amazing. They have tens of thousands of employees, and their main office is across the parking lot from Surgery Center of Oklahoma. And yet, they have no arrangement with them. Why? Because their PPO won't let them. But let's talk about the broker. That's me. One of the problems in our healthcare system is that we don't take responsibility for the problems. I hear it all the time. Hospitals blame insurance companies blame employers or the patients themselves. Employers blame the carriers. I mean, everyone's blaming everyone else. Well, I'm blaming me. I'm telling you that for the first 17 or 18 years of my career, even though I didn't really know it at the time, I was heavily influenced by the factors that the market put out there. And I had a very uncomfortable experience at a client. We get paid pretty well as brokers. And as a result, I have a nice car. I even have a driver sometimes who helps me so I can get work done. I say that because we had a client that was a lumber manufacturer in rural North Carolina. We're talking as blue collar gets. And one of my salespeople at the time had taken them from this was pre-Obamacare, so if you remember Blue Cross and their PPO plans, they really were kind of better, at least as far as the benefits go, than others. And they had one of those rich Blue Cross PPO plans. And we brought them to a very lean United Healthcare HMO plan. And my salesperson, didn't really explain the difference in what an open formulary is versus a closed formulary, for example, which I'm going to talk about in a minute. And so all these problems are going on, and I want to genuinely help the client. I also want to keep the revenue. So I pull up in my big car, and I get out of the back seat of the car. And I walk into this conference room, and there's two women sitting there with stacks of bills. And again, I genuinely want to help them. And so we're going through the bills, and I'm trying to figure out, was it coded wrong? Was it sent to the wrong claims address? Is it just the way it is? And I'm talking with them for about 20 minutes, and as I'm doing that, this gentleman comes in and sits down at the head of the table, doesn't say a word, quiet. And when I finish with the two women, I turn around to him and I said, "Sir, can I help you?" And he says, "Don't blow smoke up my ass." I said, "Excuse me?" He said, "Don't blow smoke up my ass. I saw you pull in here in your $125,000 car with your driver. Do you know that right now my wife is at home writhing in pain because we can no longer afford the multiple sclerosis medication that she was on? And she cannot be a wife to me, or a mother to our children, or a grandmother to our grandchildren or an employee to her employer because she is sitting at home because we can no longer afford that medication. He said it a little more tough, even got up and got in my face, and I'm not a physical guy, so I was very shaken by this event. And as I left there, I said, I have to change something. I can't do this anymore. It had been 17 or 18 years. Can you guys imagine if you had a job where every single client dreaded meeting with you every time? And even worse, when you had that bad meeting with the client, you then had to go to every one of their employees and explain the bad news to them? That's what my career was for the first 17 or 18 years. I won the business if I was the least shitty option. And because I was paid a commission, the worse job that I did at managing the employer's costs, the more money I made. So, I said to myself, what? I've been doing this for 17 or 18 years. I should know at this point what the problem is. But I didn't. And I said, if I don't know what the problem is, then maybe the first problem is I can't see it. So if transparency, or lack thereof, is the problem, where can I be transparent? And I said, the only place that I know of that I can be transparent is in how I get paid. So, I went to my next client, a car dealership, and I said, do you know how I get paid? And he's like, no, I have no idea. I said, well, let me tell you. I get a commission. I get a percentage. So as your rates go up, what I make goes up. But that's not it. United, Blue Cross, Cigna, Aetna, whatever, they have all these bonus programs. And I get hundreds of thousands of dollars every year in bonuses from them. And the bonuses is tied to me keeping the business with them and writing new business with them. Those are the two metrics. New business and persistency. Persistency, persistency. And once you get wrapped up in that, I know in North Carolina, the delta in compensation to me between what Blue Cross calls their presidents, or True Blue, sorry, versus their standard is 67%. Imagine for a minute if you start out as a doctor and you start off at a low salary, and over the first few years you go up in salary because you're generating really high RVUs. And all of a sudden you realize the damage that RVUs do. But now you're making $500,000, and if you stop feeding that, your salary is going to go down to $200,000. It's a tough call, right? So that's what these brokers who are advising employers are faced with. They're faced with a lack of understanding of how health insurance and healthcare really works. They're faced with a model that presents them something that seems relatively easy and pays them very well. And then you have employers that are clamoring for Blue Cross, United, Cigna, Aetna. Because again, when you intermingle healthcare and health insurance in your brain, you want a name in healthcare that you think you're familiar with, at least. And so the biggest challenge I have is separating that. So what did this change do? Well, I told them how I get paid, and I said, what if we do a different model? What if we stripped all that out? And you just paid me a fee. I looked you in the eye, and I told you what I'm going to do for you, and you looked me in the eye, and you told me how much you're going to pay me. He's like, that sounds reasonable. I said, let's go a step further. What if instead of the bonuses from the carriers, because I'm going to lose that if I do this, what if you pay me a bonus for reaching the goals you want me to reach? He's like, I love that idea. I said, great. What goal do you want me to reach? He said, I want you to lower my healthcare costs. And I go, oh, shit. But I kept my game face on, and I created a performance incentive around lowering his healthcare costs. Now, up to that point, I worked really hard for my clients. I thought that I was doing the right thing. And within the solution set that I was looking, I was doing the best I could. But when I tied my incentives to actually truly delivering what they wanted, you know what the biggest change was? I started to look outside of that standard solution set. And fast forward to today, We are now in a position where 100% of our business is not with a Blue Cross United Cigna. 100% of our business does not have a PPO network. And 100% of our business has our client paying us on a performance-based incentive. And I'm going to show you some case studies. And I'll tell you, the case studies, just so everyone knows, were literally done today. They were literally put in the slide deck an hour ago. The AV guys can back it up. And they're just the two most recent ones. We didn't cherry pick, okay? They're just the two most recent ones. So when we get rid of the broker, we typically see, and when I say broker, I'm not talking consultant or advisor. I'm talking about the way that I define it is a broker is a middleman to place insurance and gets paid a commission for doing so. And guys, I want you to know that when I post up, there was an article on ProPublica. I encourage you, Google my name and ProPublica. And it was all about the back-end compensation and the ridiculous ways that brokers get paid. And what was interesting was 2 days after this article came out, I wind up at a conference of an association that I do belong to, but is predominantly commission-based, fully insured brokers. And I was the most hated man in that conference. But I believe in this. I don't just believe, guys. Do you know in 32 states, it's illegal for a real estate agent to represent both the buyer and the seller? And in the other 18 states, it is required that it be disclosed and signed by all parties. But isn't that what a broker does every day? I'm purporting to represent the interests of the buyer, the employer, but I'm being paid by the seller. That's a major problem. And when I post this stuff up on LinkedIn, because I have a pretty big following, I encourage all you guys to connect with me on LinkedIn, please. I do push out a lot of content on there. When I push this up on LinkedIn, people really, really push back. And this one guy said, I remember, he said, it's common for every company to pay their salespeople a commission. That's not uncommon at all. I go, yeah, but those people work for that company. You're purporting to work for the other side. Don't you see the problem? That is the problem. So, when I started to tie my compensation to actually delivering what the clients wanted, that became the number one priority. Not the ease of doing business, not maximizing revenue, or not finding the best answer within a bad set of solutions. It was finding a good solution. Then I started to look at these things called networks. Now, when I was born in 1976, my mother reminds me there were no networks. You paid out of pocket, you submitted a claim, and you got reimbursed some of that. Of course, my birth in 1976 cost like $882, so it was a lot easier to do back then than a unnecessary C-section costing $38,000. But here's what I imagine happened 40 years ago. Some broker walked into some employer's office, sat down with the CFO, and said, listen, man, I know you got this health plan where you can literally see anyone you want to, but I have this crazy thing called an HMO. And the premise of an HMO is that we're going to take a high volume of patients, funnel them to a small number of doctors, and we're going to get reimbursement discounts in exchange. Furthermore, we're going to do something called capitation, which is going to put some risk on those providers for quality outcomes. And thirdly, we're going to put a clinician as a gatekeeper so that your employees don't go to orthopedic surgeons without there being a clinical reason to have them, because as soon as you get to an orthopedic surgeon, what do you think the most likely outcome is going to be? Orthopedic surgery. That's what they do. And I have friends that are orthopedic surgeons. And I have friends that are orthopedic surgeons that have ownership in the facility in which they work. And even though they're good guys and do the right thing, if someone presents with a condition that can be treated surgically or with physical therapy, it's really hard for them to say, go have physical therapy. They're comfortable with surgery. They do it every day. It's not a big deal for them. It is for the patient, but it's not a big deal for the doctor. And that's how they get paid. And if it's equally as clinically appropriate, one of the things that our medical schools have done a really poor job of is teaching anything about the cost of healthcare to providers. So, again, this broker is in with this employer and says, look at the cost difference. And that employer probably said, A network of doctors? What the heck are you talking about? I don't have a network for anything else I buy. I don't understand what you're talking about. But look at the savings. This is going to save money. It's going to improve outcomes. The same BS that they're spewing today. But the savings were big. So that CEO or CFO finally said one day, okay, I relent. The savings are too big. I'm willing to have all my employees change doctors, but there's one problem. My wife's OBGYN is not in your network, and I am never going to hear the end of it if you don't get that OBGYN in. So the broker goes running back to that carrier exec and says, if you get this one OBGYN in the network, you'll get all these members into your plan. And so they go to that OBGYN, and even if they pay them 4 or 5 times what they're paying all the other doctors in the network, who cares? It's one doctor. But that set up pressure right from the beginning for network expansion. And employers did that to themselves. They went to the carriers, you got to make the network bigger, you got to make the network bigger. And then one day, and I imagine, again in my head, that this came from HR, but HR said to, in their well-intentioned way, to their broker one year, my employees hate having to get a referral to see a specialist. Can you please come in next year with a plan that doesn't need a referral? And then, boom, we remove that clinician who was ideally limiting some of the unnecessary care. So, I'd like to show you guys a quick video. It's a shortened version. There's a longer version online. The reason I did the shorter version is I want to talk through this a little bit more than I want you to see the video, but I went to Surgery Center of Oklahoma myself. I donated my body to the cause. It was medically necessary. I had an inguinal hernia, and actually part of the reason that I did the shorter video is because in the video, the longer version, I mispronounce inguinal, and I pronounce it inguinal, and I'm a little embarrassed. So in a room full of more clinicians than I'm used to, I'm going to go with the shorter version. But I just want you to see a quick intro to the video, and then I'm going to talk a little bit more about what my experience actually was as I tried to navigate this hernia surgery through the traditional hospital and health insurance system, and then through a more free market type scenario. So, health insurance and health care are two completely different things. Have you ever gone into a restaurant and looked at the menu and there was no prices on the menu and yet you ordered your food anyway? Of course not. It sounds crazy. But yet, we do that in healthcare every day. As a matter of fact, we never ask about pricing, and even if we do, we generally don't get prices, and we don't know what the price is until we're left with a stack of bills like this after encountering the healthcare system. So for my own hernia repair, I decided to put those metrics first, the same thing you demand when you buy a car, buy a house, buy a meal. So join me as we go down that path of applying common sense to the healthcare buying decision. So here's a quick rundown of my story. Again, a longer version online, but I had a hernia in my groin. And I live in Charlotte, North Carolina, and Charlotte has 2 massive nonprofits. One is now called Atrium, used to be called Carolina's Healthcare System. The other is called Novant. We also have a for-profit hospital, which is one of the publicly traded companies based out of, I think it's out of Texas or Florida. And then we have a true community nonprofit. And I called all 4 of them and I said, I have an inguinal hernia that I need repaired. The CPT code is 98586. I'd like to know how well you repair it and what the cost is. They were like, what? One of the women, and this is in the video, she said, she puts me on hold for like 10 minutes. She comes back on and she says, you know, I tried looking up our quality stats internally and I couldn't find anything. So then I went to Google and I couldn't find anything there either. Could you imagine if you walked into a car dealership and you're like, how good are your cars? How long do they last? And like, I don't really know. And I went on Google, I couldn't find anything there either. So I could get no quality from all 4 facilities. But I tried to get pricing. At the time, I had Blue Cross and Blue Shield. And I said, I'd like to know the total cost. And they have kept trying to bucket me into my deductible. I said, no, I'm not asking you for what my share of the cost is. What will the cost through my Blue Cross and Blue Shield plan be in total? Because I own a part of the business, so the more my plan pays out, whether it's coming out of my pocket now, it's coming out of my pocket later. Those are the 2 options. So I got approximates, and I had to call 3 different places to get the price. For each facility, I had to call the facility, I had to call the anesthesiologist, I had to call the surgeon. Here was the price range. $8,900 at the low end, $47,500 at the high end, after the Blue Cross discount. Now, the high-end place was Novant. I'm going to say it. It was Novant. Their starting charge master was $90,000. When I pulled quality, and I'm going to show you some screens of how we do that in a minute, I found that Novant was the lowest quality for hernia surgeries of the four. As a matter of fact, they had the highest complication and infection rates, and they were the only one to have a death from a hernia surgery because the patient acquired a hospital-borne flesh-eating bacteria while undergoing surgery. Then I called Surgery Center of Oklahoma, and I said, I need an inguinal hernia repair, and they go, that'll be $3,060 all in. And I go, whoa, all in? I don't have to call an anesthesiologist? I don't have to call a surgeon? No, that's the total price. I said, what about quality? They said, well, we've done 313 in the last 12 months. We've had no infections, no complications, and no readmissions. That sounds pretty good. And my deductible at the time was like 10 or 12,000 bucks. So I'm like, wait a second. It's actually cheaper for me to hop on a plane, fly to Oklahoma City, get the surgery done, and pay out of pocket. So I called Keith, and Keith said, you need to see Jim Totoro, Dr. Jim. I said, okay. So I called Dr. Jim up, have a consult over the phone. He has me go to my local doctor just to confirm clinically that it is what I think it is. And then we arrange the surgery. I fly out to Oklahoma. I do my consult with Dr. Jim in the morning. And then I had the surgery in the afternoon at Keith's facility. And I said to Jim, how much of the $3,060 that I'm paying Surgery Center of Oklahoma, how much of that do you get? And he said about 1,200 bucks. I said, okay, that seems reasonable. I don't know. How much do you get when you do surgery out there at the $20,000, $30,000, $40,000 facilities? He said, oh, out there I get $800. He said, on top of that, Surgery Center of Oklahoma is so efficiently run that I can do 4 to 5 hernia repairs in the same amount of time that I would do one at the other hospital. So doctors, this is good for doctors too, this free market environment. And so many doctors are so afraid. They feel that if they don't have the money coming from the carrier, they're not going to get paid. There are a lot of backward dynamics in healthcare. One is that supply and demand are not inversely related in healthcare. When a hospital builds a new wing and puts new beds in, even though there wasn't a shortage of beds to begin with, those beds get filled. When a new MRI gets put in, even though there wasn't a shortage of MRIs, that MRI machine gets used. So what happens is supply goes up, demand goes up with it in healthcare. One of the other metrics that are backwards is that cost and quality tend to be inversely related. And what we find to be the #1 metric that sits between that is frequency. The more often a doctor or hospital does a particular procedure, the better they do it for a lower cost. So when we show employers, so this is here in the Texas market, we use a bunch of different sources of data. This is a company called Medivy, and they are mostly using Medicare data. And what we have in the blue line is what the Medicare reimbursement rate is. What we have on the green line is the billed charge to commercial insurance. And each set of bars is a different hospital here in, oh, this is Pittsburgh, I said Texas, sorry. This is the Pittsburgh area, where we actually just closed a client up there. So we have St. Clair Hospital, which is, look at the difference here, guys. Look at the highest quality hospital. This is just looking at inpatient DRGs as a total. We're going to get more specific in a minute. But the lowest cost hospital, or one of, is the highest quality overall. And this is what we see typically. I've seen some exceptions to this, but then you get into UPMC, that third hospital there, which is off the chart. And by the way, that final hospital is also a UPMC hospital. The only reason that quality scores to 0, in all fairness to them, is because they're a children's hospital, so they don't do a lot of inpatient DRGs. DRGs, as I'm sure a lot of you know, was originally created by Medicare, so it's largely used in that space, although not exclusively. And I want to point something out, guys. And I point this out, I think it has a little more impact at broker conventions that I speak at, but I ask brokers, what do you think the #1 thing your clients want to do, want you to do for them? You lower their healthcare costs. I go, great. Well, do any of you know how healthcare is actually paid for? Because if you don't know how healthcare is paid for, if you don't know what an RVU is or a DRG is, how are you going to control the cost of care? There's only one way to pay less for healthcare, folks. I know in political circles and certainly at hospital administrator conferences, they come up with all this BS terminology, but there's only one way to pay less for healthcare. You have to pay less for healthcare. That's my brilliant statement for the day. Like Uwe Reinhardt, who passed away a couple years ago, it's the prices, stupid. Period. And this whole idea of a discount, I don't even understand. These smart employers said, oh, we'll buy on a discount. You know, how many of you guys shop at Kohl's? Would you ever buy anything at Kohl's that wasn't on sale? That's ridiculous, right? But you know that even after the 60% off and even after the coupons and the scratch off and the Kohl's cash from the last time you were there, you know they're still making a profit, right? So, and I got into an argument with an Anthem Blue Cross and Blue Shield exec. He says, but we have the best discounts. And I said, you know what? You're right. I agree. You do have the best discounts. Because my hernia surgery was going to be $90,000 at Novant. You got it down to $47,000. It's almost 50%. And despite the fact that I'm good friends with Keith Smith, and despite the fact that I send patients to his facility all the time, and despite the fact that I was making a video that was going to send patients there, he gave me no discount at all. I paid his full online stated price of $3,060. So congratulations, Mark. You have the bigger discount. It's the one time I agreed with a carrier, I think, at least in recent years. So we start to show this to employers. And we say to them, like in my hernia surgery, I ask an employer, let me ask you, would you rather pay 90% of $47,000 and leave your employee owing $5,000 and they'll never be able to pay? Or would you consider paying 100% of $3,000 at the higher quality place? And they go, we would do that all day long. I go, great, well, Aetna won't let you. Cigna won't let you. You know why? Because their contract with the local hospital prohibits them from steering patients away. Let me tell you how messed up this space is, guys. If a self-insured employer has a PPO network, as almost all of them do, they sign a contract that beholdens them to pay the pricing of this other contract, the one that's actually between the provider and the insurance company. But when they ask to see that contract, they're told it's proprietary and confidential. Tell me in what other space an employer would sign a contract obligating them to pay the pricing of another contract that they can't see. Like, it's insane. It is literally insane. So we start to show them where their employees are going now. We can look at a specific hospital by hospital. And what amazes me is even within a single hospital system, the variations in cost and quality are massive. Even within the same hospital system, even looking at the same procedure. This is a DRG of 470, so this is now looking at a replacement of the joint, lower extremity without major complications. Again, looking at Pennsylvania, and I don't have a clicker, but the fourth one from the left. Okay, so this was all done for a client we just got yesterday, I think, in Pittsburgh. And they're a family-owned steel manufacturer. Matter of fact, you guys have probably sat on some of their steel because they make the landing gears for Boeing and Airbus. They make large, really high-quality steel products. And what's interesting about this company is they do about $1 billion a year in revenue. They have $250 million in cash in the bank and no debt. Their total medical spend on their 2,200 employees is $33 million a year. So this isn't a problem of affordability for them. They had two issues. Number one, they planned on being in business 20 years from now, and they know at some point it's going to be unaffordable to them. Most clients come to me at the point at which it's unaffordable, or usually like 5 or 10 years past that point. But that's not the case with this company. They were concerned about two things. One was the trend, and the second was the quality of places where their employees were going. Now, Heritage Valley Sewickley is a small hospital. We actually have a meeting with their CFO in 2 weeks. And what we're going to do is we're going to battle UPMC. We're going to create deals with all the other hospitals that are desperate for steerage away from UPMC. We're going to find the best ones. We're going to make deals on what they do best. We're going to pay them a fair amount. We're going to pay them with no member out of pocket so they don't have to collect any debt from any of the patients. We're going to promptly pay them so they don't need revenue cycle managers to figure out how to get paid. And we're going to use those efficiencies to pay a lower price. And we're going to steer patients to that higher quality, lower price place by saying you can go where you always went and your really high deductibles apply, or your employer cares so much about you that if you go to the highest quality place in the area, you're going to pay nothing. So we're going to go and approach these smaller hospitals. We're going to create sweetheart deals. And then we're going to go to UPMC and say, you know what, guys, we don't need you. But if you want to play, here's what it's going to be. I don't think anyone's ever approached UPMC like that. But I think it's the only way to work. Now, this employer needs to be willing to say goodbye to UPMC, but 5,000 lives is not a small amount. And we'll see what kind of traction we get. But the whole point is, all the UPMC hospitals here are the higher cost, lower quality. So even if they weren't in network, who cares? Now, let's talk about it. Now, our plans have no networks, but Tom Emmerich is a friend of mine. He used to run Walmart's program. And Walmart's 1.2 million people. And they went to United Healthcare, and they said, guys, we've done tons of data on our claims. Because a company like Walmart, they can get the data. More importantly, they have the money to know what to do with the data. And what they found was that 40% of dollars were going to the bottom 3% quality of providers. So they went to United and they said, we just want to eliminate that bottom 3%. This is Walmart, the largest employer in the United States. Carriers said, we can't do that. Their contracts won't let them. And again, back to my earlier point, they can afford to lose Walmart. They can't afford to lose UPMC. It happened and it killed Blue Cross in Western Pennsylvania. Do you know what Blue Cross had to do to survive? They had to buy their own health system. They bought Allegheny Health System just so they could have hospitals in Western PA. So when we start to show to employers, and you know, have you guys ever walked through the Pittsburgh airport? I did just a couple weeks ago. UPMC is everywhere. You would think that if you're on a UPMC health plan or being provided care by a UPMC doctor, that you are the happiest, healthiest person in the world, because that's the picture that's up everywhere. But yet the data shows that they're the highest cost and lowest quality in most cases. The insurance carrier. Guys, I am blacklisted by insurance companies. When I speak at events that insurance companies are sponsors of, they walk out at some point during my speech. Oftentimes, they pull sponsorship dollars. But most employers have no idea how insurance companies make money. And if they knew, I can't imagine that they would allow to go on what's going on. So first, let's prove that insurance companies are making money. I think their share price being up 300, 400, 500% more than the Dow Jones and S&P since Obamacare passed is indicative of that. They are making a lot of money. And I use United Healthcare as an example in lots of different ways because they're such a behemoth. But there's a couple of stories I want to say about United. How am I doing on time? Okay, good. Still got half an hour. So United Healthcare has two main sides of the house. They have United Healthcare Insurance, and they have Optum. On the insurance side, it's bifurcated into two different sections. Commercial market, which is employers and individuals, and then the government, which is Medicare, Medicaid. Now, on the Medicare side, when a Medicare beneficiary chooses one of those AARP United Healthcare plans, because that beneficiary is coming off the liability of the government, they pay United Healthcare a capitated monthly fee. So in that environment, if United Healthcare keeps costs down, their profit goes up. Well, if you read their annual reports, you'll see they're very good at keeping costs down. Their profit on the Medicare sector is up more than any other sector on the United Health Insurance side and is expected to grow even more in the coming years. On the commercial side, things are a little different. See, on the commercial side, we have something called medical loss ratios. It's a provision of the Affordable Care Act. And what medical loss ratios say is that an insurance company must spend out at least 85 cents of every dollar it spends on healthcare costs, of every dollar it collects in premium. So if in 2014, the carrier brings in $1 million in premium, they must spend $850,000 of that on healthcare costs. If next year they want their margin to be $165,000, the only way to get there is for their underlying healthcare costs to go up to $935,000. And the year after that, if they want $181,000 of margin and profit, they have to allow healthcare costs to go up to $1,028,000. So on the insurance side, the non-Medicare side, the commercial side of the house, guess what happens every year? Costs go up. So I posted up the other day, how can David Contorno from Mooresville, North Carolina, negotiate a better contract with a UPMC, or any hospital for that matter, than a United or a Blue Cross? This is what employers think. And I said, I can't. They could negotiate a much better contract than I can. They just choose not to. So would you rather have someone that is okay at it, but working in your interest, or someone who's really good at it and not doing it at all? If insurance companies were incentivized to keep costs down, this is what their revenue model would look like. And if I'm the CEO of United Healthcare and I walk into a shareholder meeting with something like this, I'm not going to be the CEO for very long. But here's what's even more messed up. You got this other company called Optum. Optum's #1 revenue source is their PBM. I'm going to talk about that in a minute. But do you know that Optum also owns a revenue cycle management company? Now, a revenue cycle management company is designed to help hospitals get paid as quick as possible, as much as possible from the insurance companies. How can they be saying over here, we're going to help you get as much money as possible, and they're saying over here to employers, we're going to help you save as much money as possible? By the way, I find that same thing occurs when I go into large doctor practices and they want me to help save them money on healthcare. I'm like, well, you got to pay less for healthcare. Well, they don't like to get paid less for healthcare because that's how they get paid. It's a very interesting struggle to watch. There's a TV show on TV. It's called The Resident. And for those of you that heard or saw Dr. Marty McCary, I think I saw him walking around here a minute, that show is based on his book, Unaccountable. And there's a scene in one of the earlier episodes. The revenue cycle manager consultant comes in and she says, you know, when someone presents with an ear infection, it could be an ear infection, or it could be a possible brain infection. And she puts up this acronym, CUTE, C-U-T-E, Code Up to Excellence. And although that's a bit dramatized, that is what actually occurs all the time. And I had it happen to me. Let me tell you the story of my son. 6 years old at the time, Tuesday evening, he is really bad abdominal pains. So I'm thinking, appendix. It's 7:45 on a Tuesday night. I'm not a clinician, so I just play one on TV. So I said, what's the right thing to do here? 7:45 on a Tuesday. What would I tell a client? Urgent care. Don't go to the emergency room yet. I didn't have a DPC doctor at the time. I do now. So I call up urgent care. They're like, well, we're open till 8. You better get down here fast. So we go rushing down to urgent care. Doctor doesn't even look at him and says, we're calling an ambulance, and he's going where? Novant. I said, whoa, 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 whoa. Why an ambulance and why Novant? And he said, well, an ambulance because he's clearly in pain, and Novant because it's the only place that admits pediatrics for surgery. So if he needs to have his appendix removed, that's where he's going to have to be anyway. And I said, you're not calling an ambulance. I'll take him there myself. So I take him down to Novant, and it's about an hour and 15 minutes before the hospitalist, when did that phrase even come into being, walks into the room. Within 7 seconds, he goes, oh, that's not an appendicitis. I go, he didn't even touch him. I go, how do you know? He said, it's on the wrong side of the body. I said, well, that would have been good to know an hour and a half ago. He said, it's probably just a backed up constipation. Let's do a quick x-ray. They do a quick x-ray. Turns out that's what it was. They give him an enema. My 6-year-old poops out the biggest poop I've ever seen about 30 minutes later. And he feels better. And we go home. And then I get the bill. $3,900, which was actually a little less than I was kind of scared of. And I do something that most people don't do. I call up and I ask for the itemized bill. And when I get the itemized bill, the #1 charge on there is LVL4ED. Level 4 emergency department. What does that mean? So I Google it, and I come to the American College of Emergency Room Physicians coding guidelines. And there are 5 levels. 5 is like you're already dead. One of the examples they gave for level 4 was cardiac arrest. Constipation and cardiac arrest didn't seem to be on the same level. So I called Novant and I said, I think you guys miscoded this. And they said, well, we have a clinical review team. We'll send it to them and we'll see what happens. We'll call you back in a week or two. I don't get a call back. So I call them back. And they said, oh, yeah, we reviewed it. We determined it to be appropriate. We're not changing it. And I said, guys, I don't think you understand. I'm not asking you to do me a favor. I'm asking you to follow the national coding guidelines. And they said, well, we'll send it back for clinical review again. And I said, well, can I speak to one of these clinical reviewers? No, you can't talk to them. So they said they'll call me back in a few weeks, and a few weeks later, nothing. They won't change it. It is what it is. And I said to them, let me ask you a question. I asked them why. Why are they saying they won't change it? It's not appropriate. And they said, well, the doctor thought it might have been an appendicitis. And I said, okay, so if I come in with a really bad headache and the doctor thinks it's a brain tumor, but it turns out I just drank too much wine the night before, are you going to bill me for brain cancer treatment? So I opened up with a couple of other people the North and South Carolina chapter of the Free Market Medical Association. And when we had our opening meeting, we had a bunch of people that think like we do come. And I tell them this story, this bill. I'm all fired up again. I had already paid it because I had the money. I had the $3,900. And it was about to go on my credit, so I paid it. But I get all fired up when I tell them this story, and they're just like, that's ridiculous, whatever. So at that point, I had a pretty strong following on LinkedIn. And again, please, guys, connect with me on LinkedIn. And I post up on LinkedIn a picture of the bill, the whole story, and I tag Carl Amato, who's the CEO of Novant, which is a $3.2 billion health system. Well, because of my following, a lot of people like, comment, share. And every time that happens, if you've ever been tagged on LinkedIn, you get a little ping. Someone liked a comment that you're tagged in, so this Carl Amato starts getting boom, 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 like 2,300 likes, 7,000 comments, and a couple of hundred views or shares. And he actually comments. And he says, David, I'm going to have someone reach out to you. So this woman reaches out to me. Her name is Kim Jones. She's head of customer service. And she actually adjusts the bill down to the level 2, which was a $1,900 difference. She doesn't call it miscoding yet. She says as a customer service because they never call me back when they were supposed to. But she says we do follow clinical guidelines. So I'm going to get you what those are. And if it was miscoded, we're going to fix it. And I'm like, oh my God, is this like a hospital system that really tries to do the right thing? What is going on here? Now, let me sidetrack for a second. I often talk about how we have Stockholm syndrome in this country with insurance carriers. Patients say to the insurance company, who may I go see? Who's in my network? And what is it going to cost me when I go there? What's my deductible and copay? And once they get to the doctor's office, the doctor says, hey, Mr. Insurance Company, what prescriptions can I prescribe? And what treatments can I do? And how much I can get paid for it? Employers go to insurance companies and say, hey, Mr. Insurance Company, what benefits can I provide my employees? And how much is it going to cost me to do it? Brokers, we go to insurance companies and say, hey, Mr. Insurance Company, what products and services can I offer my clients? And how much are you going to pay me to offer it? So we all have Stockholm syndrome in this country, I believe, with the insurance company. So back to the hospital story. Kim Jones gets a lot slower at returning my emails and phone calls. And eventually I get an email from one of their attorneys, a pretty lengthy email. And basically it says that we don't follow national coding guidelines, and there's actually no requirement that we do. By the way, that's one of the problems. And if I see Marty's book on Accountable sitting there, and one of the things that actually he and Atul Gawande wrote in the patient manifesto was a national standard around just pre-OR practices. I mean, I had a friend in the hospital, and he counted every time a clinician came in who sanitized their hands. It was 1 in 3. 1 in 3, who just came from another patient's room, most likely, with some other disease or some other infection. 1 in 3 are sanitizing their hands. But anyway, I get this letter from the attorney. They say, we don't follow national guidelines. We use a software to do this called Optum 360. So even they are relying on that. So anyway, coding is a problem, we know that, but the point is, and what I try to explain to employers, the main point is that there's a line, and on one side of the line is you and your employees, and they're hurt by rising costs. And on the other side of that line is literally everybody else, your broker, your health insurance carrier, your hospital systems, your drug companies, your PBMs, everybody who make more money as costs go up. So, when we get rid of the insurance carrier and we go with proper TPAs, for example, one of many, but Micah, my friend from EBMS, they have a TPA that we use pretty frequently because they have a team of people that help support us in developing best practices around how to pay doctors and hospitals, around creating payment methodologies completely outside of the network space that allow us to pay for care in a way that's fair for the doctor and fair for the real payer of healthcare. For anyone in here, by the way, that ever calls a carrier the payer of healthcare in front of me, I will chastise you. The carriers are as much the payer of healthcare as my accountant is the payer of my taxes. They just tell us what to pay and how much, but they are not paying the bill. Now, this last section I'm about to go into. When I'm speaking to employers, most of them are fully insured or in a bundled plan with a carrier where they don't fully understand what a PBM is. But when I talk about how dirty our healthcare system is, see, most of America is under the false impression that as a whole, we have a high-quality healthcare system. And that simply is not true. Now, present company excluded. But the whole point is that they think everyone is as good as you. Matter of fact, they think you guys are the ones performing low-quality work. It's absolutely backwards. But what I say is that if you think that's dirty, that's Mother Teresa compared to what happens on the pharmacy side of things. So most people don't even know what a pharmacy benefit manager is, but this is the number of sources of revenue that the traditional PBM has. 72 sources of revenue. Now, the most common ones are up near the top. Clawbacks, spread pricing, rebates. Let's talk about rebates for a second. I'm sure most of you know what a rebate is in a drug world, but it's really a bribe to the PBM to not only include them on the formulary, but include them in a preferential way. So this steel company that I was telling you about, they had Caremark for their PBM. I said, do me a favor. Tell me if you see drugs like Duexis and AviQ on your drug fill list. Now, for those of you that don't know, Duexis combines the amazing benefits of generic ibuprofen with the amazing benefits of generic Pepcid in a $3,500 a month pill. But there's a $1,000 rebate. So PBMs who process transactions, they don't pay for drugs, they don't make drugs, they don't deliver drugs, they like the rebates because they get some or all of it in most cases. But what's even worse than that is spread pricing. And just, again, I know there's probably a lot of different people in here, but let me tell you what spread pricing is, at least from an employer's perspective. When an employer signs a contract with a PBM, they agree to pay a price on a drug that is something called average wholesale price, AWP. Some people call that ain't what's paid, minus some sort of discount. 17% maybe on name brands, 80% on generics, whatever. So you have this floating AWP, and it changes daily, and there's a couple of aggregators out there that monitor it that they supposedly pull from, although we often audit PBMs and find that they're just making up AWP. And then when the claim comes in, when a member goes and fills a drug, what the employer sees is the price minus the discount plus an admin fee to the PBM, right? You got to pay them for conducting that transaction. $5, $2, it's all over the place. So let's pretend that it's a generic drug. The AWP is $100. So the 80% discount brings it to $20. And let's say that that PBM is charging a $5 fill fee. So the claim comes in to the employer as $25, right? Or maybe if there was a $5 member copay, it comes in as $20. $5 member copay, $5 fee to the PBM, $20 for the drug. What do you expect goes to the pharmacy? $20, right? Because $20 was the cost of the drug. $5 went to the PBM. But see, PBMs pay pharmacies on a completely different metric. The agreement between the pharmacy and the PBM says that we're going to pay you something called WAC, wholesale acquisition cost. And what the PBMs have done is they've ensured that whatever that AWP minus discount is more than the WAC price. Therein lies the spread. And some of that spread goes to the PBM. I've seen that spread go to the TPA. I've seen that spread go to the broker. Imagine for a second if I sold you a stock, bud. It's trading on the market at 80 bucks. But I not only charge you a fee, but I sell it to you at 90 bucks a share. I'd be sitting next to Bernie Madoff right now. But in healthcare, it's done all the time. Now, not all PBMs are created equal. There are a couple different contracts. And even this is wishy-washy, but a pass-through contract is the only one that we support. And that means that if WAC is below AWP, then WAC is what the employer pays, period. It means that 100% of the rebates go back to the employer. Now, there are some employers or some advisors that are big enough to go to Express Scripts or Caremark and say, I want these provisions in my contract with my client. Here's the problem. That may be true for that one client, but Duexis is still going to be on your formulary because they're making money on it on 99.9% of their other clients. So you have to be with a PBM in which their entire book of business is like that, so that none of those perverse incentives exist. The way we even buy drugs. Oh, one thing on Duexis and Auvi-Q. When I brought this up to that steel manufacturer, and they saw that those drugs were in fact being paid for by their plan, they went to Caremark. And they said, Caremark, we want a formulary that removes these low-value drugs from our plan. And the Caremark says, we have that. We'll do an analysis. We'll get back to you. And they come back a week later, and they say, we did the analysis, and the administrative costs are almost exactly the same as what the reduction in spend would be, so you might as well just keep them in your formulary anyway. So the PBM is charging more money to remove drugs from their formulary because they're making money on them. This is an actual analysis done on a client. And the green bars is what's going on within their plan now. And it's showing the actual discount. So one of the things for any of you employers that are self-insured and you are dealing with these types of decisions, in most cases, when they say a 17% discount off of AWP, they don't mean 17% on every drug. They mean an average. So you might get, and here's the thing about averages, guys. Do you average it over the number of drugs, or do you average it over the actual dollar amounts? See, they can play with that average multiple different ways and claim they're delivering a 17% average value reduction when really they're delivering a 5% reduction on the high-cost drugs and a 25% reduction on the low-cost drugs. So you got to look at it much deeper than just discounts. Discounts don't mean anything, and all they do is lead to higher starting prices. So we work with different kinds of PBMs, ones that are 100% passed through on everything you do, flat administrative fees, even fees at risk, even a per member per month fee, so it doesn't matter how many drugs are filled, because we put in a ton of programs that encourage employers and employees to fill drugs outside of the retail pharmacy and PBM channel. We import drugs internationally at around 70% reduction in cost. We export patients to get medications. We have this one medication. It was costing $85,000 a month through Cigna. We moved the group to a proper TPA and a proper PBM. We brought that down to $45,000 a month. Okay, still expensive. Last year it went generic. And as it was getting ready to go generic, I'm like, oh my God, this drug has been the bane of my existence because it's single-source drug from Accredo, which is owned by Express Scripts. When it goes generic, it goes from $45,000 to $41,000. So this patient is actually flying to France in a few weeks. It's a mother-daughter, the drug's for the daughter. The employer's paying all the travel. They're going to go to France. They're going to get 90 days worth of medication. They're going to do that every 3 months. And every 3 months, that's going to cost $55,000 for the 3 months instead of $41,000 for the 1 month. And this employee gets a free trip to France every 3 months. I'm going to have to try and find some other location for it because I don't know, I get sick of France after a while. PBMs are making so much money. Do you know that Express Scripts, I use them as an example here because they are only a PBM. They don't do anything else. They are the 22nd largest company in the US. For all of you guys that own businesses and gals, I suggest you take your total revenue and divide it by the number of employees you have to just get an average revenue per employee. Theirs is $1.8 million. Find out what yours is. Now, another place, and there's wide variations in cost, is, how am I doing on time here? Okay. At the pharmacy level. This is showing 5 drugs that are possibly prescribed together. And on the left side, it's showing different places to fill those drugs and what the total price is to fill those drugs. To fill the same 5 drugs ranges from $66 to $928. We oftentimes exclude Walgreens and Rite Aid from our formularies completely, because wherever there's a Walgreens or Rite Aid, there's usually something lower cost across the corner. I'm going to go to some of the solutions here because I'm running short on time and I know we have a happy hour coming. The way that we create a plan is we completely get rid of the network because the network is what handcuffs us. The network is what prohibits us from doing what I'm about to describe. And I've already alluded to this, but it's really simple. We say to employees, you can go wherever you want to go. And if you go where you've always gone, you're going to pay what you've always paid. We typically match their current benefits. But we create this alternative pathway into the healthcare system. We give them a set of benefit concierge people that have access to real quality and cost metrics and can help steer people to the absolute right place of care. And when they do that, when the employee lets us do that, when the patient lets us do that, the employer pays 100% of the cost. That not only eases a huge financial burden to the employee, but it also eases a financial burden to the provider and to the payer. Why do I smell bacon all of a sudden? Am I the only one smelling that? It's you? So it's really that simple. We help employees, patients make intelligent healthcare decisions. We spend more effort on the care than the insurance, just like we spend more effort on driving the car than the car insurance. And that's how we created a plan. I'm proud to be associated with an organization called Health Rosetta, which was founded by Dave Chase and Sean Shanson. I was one of the first advisors to be part of the program. And what we've done is we've set a list of what a high-performing health plan needs to look like. It has to hit every single one of these. Transparent pharmacy benefits. There's no coincidence that that is first. Transparent medical markets. That's what we do here, right? That's what we are all here fighting for or providing already. Value-based primary care. I am a huge believer that we need to put more dollars into primary care in this country. As a matter of fact, even though we spend the most amount on care of any nation by far, we spend the least as a percentage on primary care. And the problem with primary care, for those of you that don't already know this, and I'm sure a lot of you do, is that the insurance companies have devalued primary care so much to the point that they get bought up by the large hospital systems, and then the large hospital systems use them as feeders into the rest of the system that makes them more money. That's what the RVUs are for. So we need better primary care, and I'm really proud to be here with Dr. Shane Purcell, where we put a county plan in place where we embedded direct primary care into the plan fully, and we said to employees, if you choose the direct primary care plan, everything's covered 100%. You know what else we did? We said to the direct primary care doctors, you don't need to ever worry about prior authorization, pre-certification, step therapy. If you say it's necessary, it goes, period. and it's paid for 100%. Companies are already doing this. Now, remember the earlier conversation I talked about when that broker 40 years ago walked into that employer and talked about a network, and the employer was like, what the heck are you talking about? And now here I am 40 years later talking about getting rid of the network, and they're like, what the heck are you talking about? I can't go to see a doctor without a network. Employers are doing this. And what I want to show you last are 2 case studies. And these are just, again, the 2 most recent ones. They're not anyone special, okay? This first company, this is looking at a 3-year time period. They were with Cigna from 26. Their plan year runs April 1st, so that's why you see the 2016 to 2017 plan year. They spent $4 million on 363 employees. Now, in the first year, they wouldn't let me get rid of the network. They were too scared. But they did let me put them with a proper TPA, a proper PBM, and despite the fact that the PPO wouldn't let us do it, we went ahead and got a second TPA to adjudicate claims at the transparent free market providers so that we could send patients there and still waive the out-of-pocket even though Aetna didn't want us doing it. And we saved that first year 37.43% for that employer. Then they let me get rid of the network. Now we're down 49.24%. So $2.5 million on 384 employees. Guys, to a company, that is, and I will not work with a company if they don't agree to share that with the employees. So what happened this year, for the second year in a row, was that everyone's payroll deductions went down by another 10%, went down 20% last year, 10% this year. We lowered their out-of-pockets. We increased physical therapy benefits because they're in a pretty physical environment. We saw a lot of orthopedic surgeries going on that weren't necessary. So not only did we increase physical therapy benefits, but we gave them the first bunch of visits at no copay. We want them going there first. We're putting in a mandatory second opinion program for all oncological and musculoskeletal. Party starting. So we're doing even more this year because my compensation is tied to it. I want to keep doing more. I want to improve outcomes and I want to lower costs. So this was on a 400 employee company. This company is a little smaller, and in this one, I mainly use this slide to show for employees, for brokers, 2 things. Number 1, this client in 2018, before we were their broker, already had a no-network plan. Well, largely no network, I should say. They had a network of doctors, but they had gotten rid of the network of facilities. They were with EBMS. They were with a good TPA. And they were spending $6,640 per employee per year. So far this year, since we made the changes 1/1, they're down 48.75% from that. And all this came with a reduction in deductibles and a reduction in out-of-pockets, and at least the first year, no increase in what comes out of their paycheck. We'll get the decrease next year. A lot of employers, they want me to prove it to them because one of the things the insurance industry has done is they've done a really good job of not delivering on their promises. One other thing that I'll say, medical trend. And again, I use Keith Smith as an example here. Insurance companies love coming out and saying, medical trend is 11%, and your increase this year is only 8%. See how good we are? Medical trend is a number that is completely fabricated by the hospital systems and the insurance companies for the sole purpose of setting employer expectations so low that they can come in with a 5 or 6% increase and the employer can say thank you. But what's driving that? You know, Keith Smith told me that since he opened his doors in 1993, he too has had 4 price adjustments. All 4 of those have been down. Now, I presume he's using the same anesthesia on me that the other hospitals do. I presume the mesh that was implanted was from the same or similar manufacturer. I presume the heart rate monitors and the beds are all being bought from similar places. So how is it that he can do it for $3,000 and Novant is charging $47,000? Well, number one, when I tell people that when I went to his facility, he had 1 part-time person in his entire billing staff, every hospital literally looks at me like I have 9 heads. That's just not possible. Where most of this money is going, guys, is even worse. Over the last 20 years, there's been a 5% decrease nationally in clinical staff. There's been a 2,600% increase in hospital administration staff. It's absolutely absurd, and it is fixable. So for those of you that are providers or facilities or employers in the room, this is fixable. And what I will say, I'm going to leave you with some hope. 4 or 5 years ago when I started down this path, I was told I was crazy every which way to Sunday. These carrier execs in their fancy suits and their cuffs were saying, this is you're nuts. Employers were saying, you're nuts. Employees were saying, you're nuts. But it's actually changing, and the groups of people who believe like we do are growing. And employers are starting to wake up and see. We're getting less and less resistance, larger and larger employers to say yes. It's happening. And so I encourage you guys to just keep up the fight. This is the right time. This is the right place to burn the ships, to change this. I think that this should be our #1 national priority. This is the thing that we should be embarrassed about the most as a nation, is our healthcare system. Not just the low quality and high cost, but the absolute and utter dysfunction that occurs within it. So I really commend everyone in this room for not taking the easy way, for not taking the most profitable way, but for taking the right way. And I think that that's going to come back and pay you guys in spades very, very soon. Thank you, everybody. Thank you, sir.
Can you take 2 or 3 questions?
Yeah. I'm embarrassed.
Let's go for 2 or 3 questions. It'll make the drinks taste even better.
Yeah, sorry. Repeat the question. I said I would do that, and I didn't. So this gentleman said, I think he's a broker or consultant. Is that right? It sounded like? Consultant. So it sounded like he has an employer in Detroit who has a large union population. How do you get a union to even buy into this? And I don't know that getting a union is any more difficult. It's difficult across the board. One thing I would say to that employer is that we've been able to successfully save so much money, we've been able to kick the union out. I don't know that I'd say that to the union, but to the employer. But to the union, this is not decreasing benefits. That's the whole thing. This is increasing benefits from day one. And that's what they're concerned about the most. Now, I know they have this incredibly strong loyalty to Blue Cross, but I think the presentation that I did today, just so you know, and I'm happy to give you a copy of it, is what I show to employers, because when I started off talking about my solutions, I didn't get a lot of traction. And the reason, I think, is because they didn't fully understand the problem. And so with employers that have unions, they're probably on the larger side. You can get data, and I'd be happy to help you. We can show them how dysfunctional their plan is. Not just the cost, they kind of know that, but how bad the care is that their employees are getting. So I think it's really about education. It's showing them how dysfunctional it is and showing them that most of their pressure is coming from the cost of healthcare. And if we can solve that for them, everything gets better. They get more members, they have more money in their budget. But I will admit, municipalities and unions are very difficult in this. But I'll be happy to talk in more detail.
Not being involved in that aspect of the business, it's difficult to understand. So my question is, the information you're giving to us in many ways is proprietary to you. This is your baby that you have put together. Are there sources of information in language that is understandable in a way that when you go to talk to a semi-pro, which is usually what you talk to before you get to where the real action is, they understand that you understand and mean business?
Yeah, that is a really tough thing. This is a very complicated thing, and I barely even touched the surface through what I went through. But It's the very complexity that you're talking about that we look to reduce. One of the things that I explained to an employer is there are really only 3 entities I care about. There's the patient, the provider, and the payer. Everyone else is noise. We want to minimize or eliminate those as much as humanly possible. And so I explained, thank you, I explained that the more people you put in the middle, the more money it's going to cost, the less you're going to see. And let's think about what a doctor's office really is. It's a business, right? And if a customer walks in, a patient, with a way to pay, with a service that's needed that they can provide, who's going to say no to that? That's the biggest fear, is getting rid of the network. That's where the fear comes in, getting rid of the network. But I think here's what I would do. If any of you guys are Seinfeld fans, when I started down this path, I took the George Costanza method. Remember, he was having trouble dating women? So he said, what if I just did the opposite of everything? Let me try that. So the next woman he walks up to, he says, hi, my name is George Costanza. I'm 45 years old. I live at home. I'm unemployed. I'd like to go out with you. And she said, sure. And to some extent, that's what I did, is I just did the opposite of what everyone else was doing because I wanted to get the opposite results. It's not as complicated as we think it is, or it doesn't have to be. And so I think one of the things is to stop being so afraid. And once you start to really believe that healthcare and health insurance are 2 different things, and all I'm really changing is health insurance, it doesn't become that scary. We're just changing who's cutting the check. That's really it, when you really think about it. But that is a tough question, and people think it's complicated, and it is complicated. It just doesn't have to be. So that's the best answer I have for you at the moment, but I'd be happy to talk further. Got one more?
Hi, Mr. Contorno. Thank you for coming in. My name is Kush. I'm a medical student at Stanford. I was really inspired by your talk, actually. I think it's phenomenal that you're able to affect so many cost savings by negating care networks. One of the things I was curious about, you mentioned capitation, and I've read that one of the problems with that in the 90s was that even though employers paid providers, or they paid the carriers by capitated models, the carriers would have fee-for-service payments towards the actual care delivery methods. Yeah. So is there any way of meshing capitation with some of the methods that you've talked about?
I think ACOs were an attempt to do that. The problem with ACOs is we went to the traditional players to manage them. And so, of course, they were going to insert traditional things. But we're building an ACO with the health system directly. And what we're doing is we're looking at the patient population and what the spend is, and we're going to create a shared risk model for improving clinical outcomes. I think that makes total sense. Put a little risk on the employer and a little reward on the employer and a little risk on the providers and a little reward on the providers. We're not talking about a 100% swing or a 90% swing, but most people have performance tied to their job that's based on actual outcomes. And guys, I want doctors to get paid well. Doctors are the #1 suicide rate of any profession in the US right now. There are fewer people going to medical school. I commend you for even doing that, and it's unlikely, but I hope it's in primary care, but that's where the least amount of people are going. But we want to pay providers fairly, and we do pay providers fairly. Like we said, in my own surgery, the doctor got 50% more than he gets. But he did a high-quality job. He deserves it. And what we should be looking for are those high-quality providers and paying them well and doing all we can to send patients to those providers as much as possible. But at the end of the day, I don't think either one of those works. I think having clear, posted pricing and quality and letting the consumer decide what is value. I asked an insurance company, they're creating these high-value networks, right? That's what they're calling them, high-value networks. I said, well, how do you determine value? More importantly, no matter what answer you give me, what hubris is it of you to determine value for the patient who's consuming it? When I go to the Walmart to buy my groceries, I might buy the store brand pasta or I might buy the Ronzoni brand pasta, but that's my decision to make. I might buy an Audi or I might buy a Hyundai. That's my decision to make. I think it's even more important as a patient. And so I think the value and what am I getting in return for what I paid should come from that patient. So I even envision a day where we see, okay, an MRI, we can get a decent MRI for $600, which is high by Kristen Dickerson's standards, I'm sure, if she's here. But if we can get an MRI for around $600, imagine if we said to that employee, here's $600, go get your MRI wherever you want. Now they're going to be really caring about price. So we need to put some of that, that's where the consumerism comes in. And by making those two doorways that I make, I'm trying to like force that consumerism around people because they just don't do it in healthcare. But that's what really needs to happen. And we need to get rid of all this convoluted stuff. I hear stories in North Carolina before I moved there that like people would show up with a chicken to their primary care doctor to treat their child for strep throat because that was really all they had. And like they're exchanging value right there. Here's my chicken, please treat my child for strep. But there was value, there was an exchange there, and that's missing. And that's part of the problem with our healthcare system is the consumer and the payer are two completely separate entities, at least immediately. At the end of the day, they're the same, they just don't realize it. But it's all of thinking. Fear, uncertainty, and doubt. That's what's preventing us from fixing this, nothing else.
One last question right there.
Can you talk more about how you get more of the employees interested in this so that they're the ones that are asking their employers to plan rate for this? Because when you're showing your per employee per year cost going down, that's from the employer perspective.
Yeah.
But at the end of the day, a percentage of that is going to be on the employee too, right?
Yeah.
So how do you get more people, like you're saying, word of mouth will tank a business or it'll help it succeed. How do you get more of the end user, the patient, talking about this amongst themselves, their friends, their family, so that they're going to their employers, asking their employers for more plans like this instead of the status quo?
You know, I have to admit, I haven't tackled that question yet because what I've been tackling for the last 4 or 5 years has been, once the employer says yes, how do I get the employee that I now have an audience with to say yes and support it? And that's hard to do. We have a client actually in Livonia, Michigan, right outside of Detroit. They are a tooling company. And when we announced we were leaving Blue Cross and Blue Shield, 2 employees quit before the change even actually occurred. Well, that little tooling shop, 109 employees, is known for having the best damn health insurance plan in all of Detroit. They have people clamoring to come to work for them because of their health plan. Both employees asked for their job back. They only let one back in. So there needs to be some modification of that, I think. We need to show the benefits and say to employees, imagine if we could show you how to get the highest quality care and your employer paid 100% of it. But we haven't gone that angle yet. But I will say that the employer demand is going up dramatically right now. And it's through the employer-employee market that I think we need to tackle this. But I haven't thought about how do we get the employee to beg the employer. Once or twice we've had employees leave a company that had one of our plans, go to another company, and they push up and have them call us, but not all the time.
Perfect. Please join me in thanking Mr. Contorno.